Hello. Today I'll be talking to you about compression neuropathies, the basic concept of compression neuropathy, as well as I'll divide this talk into three segments, one for the median nerve, one for the ulnar nerve, and one for the radial nerve. Now, just few common phenomenon of compression neuropathies. Basically, in the upper extremity, we discuss about median nerve, ulnar nerve, and radial nerve. In the median nerve, you have three segments of area which can cause compression neuropathy, namely pronator syndrome, anterior interosseous syndrome, and carpal tunnel syndrome. And on the ulnar side or ulnar nerve, you can get cubital tunnel syndrome or ulnar tunnel syndrome at Guyon's canal. And on the radial nerve side, you can get radial tunnel syndrome, posterior interosseous syndrome below elbow, and Wartenberg syndrome, which is in the radial cutaneous nerve in the forearm. You can have some other neuropathies across the board, which could be in the upper extremity. You can get cervical root compression, thoracic outlet syndrome, quadrangular space syndrome, to name few. In the lower extremity, you can have femoral nerve entrapment. You can get lateral femoral cutaneous nerve entrapment or meralgia parasthetica. You can get saphenous nerve entrapment, peroneal nerve entrapment, tarsal tunnel syndrome, and varieties of unnamed nerves can also be trapped, so long you know the anatomy and what nerve is in that area. On an average, the simple thought process of compression neuropathy is it's either a mechanical, vascular, or ionic causes, and also one has to have a comprehensive, thorough knowledge of anatomy to figure it out what nerve is involved. Good history taking, proper clinical evaluation is kind of mandatory. And by the way, the present consensus is that possibly the vascular compromise of a segment of action is the reason you have all the symptoms of compression neuropathy, period. The pathogenesis of compression neuropathy has to be anatomic, postural, developmental, inflammatory, metabolic, endocrinal, tumors, trauma, iatrogenic. For example, in anatomy, transverse carpal ligament is an anatomic structure which can create compression of the median nerve, or a postural position of flexed wrist also can cause carpal tunnel syndrome. Developmentally, if you have an anomalous muscle, bone, or some kind of a fibrous band, they can also cause compression or entrapment of a nerve. Synovitis as an inflammatory factor can also cause that. We all know pregnancy, premenstrual people can have carpal tunnel syndrome, which is transient. Hypothyroidism also can cause carpal tunnel syndrome. Diabetes can have an additional effect on carpal tunnel in addition to neuropathies. Tumors like ganglion, lipoma, trauma, bone fracture like mid-third humerus can cause radial nerve entrapment, and iatrogenic, intraoperative, postoperative, injection, etc., can also cause symptoms of carpal tunnel. Now, again, we need to know a careful story about location, duration, nature and time of onset, periodicity, where does it radiate to, injury, acute or chronic, and provocative or relieving factors or associated medical issues. This information should be with us because it will help us to make a diagnosis in a comprehensive way. The knowledge of which nerve supplies which muscle, or rather which muscle is supplied by which nerve, is important. Namely, what are the muscles median nerve supply, what are the muscles ulnar nerve supplies, as well as radial nerve supplies. This knowledge gives us a clue about which nerve we are dealing with, and some salient points becomes important. For example, if a patient comes in with an interosseous wasting of a muscle in the thumb area, we kind of know this is not going to be medial nerve, it may be ulnar nerve. So the anatomy and muscle innervation is important. So this is a feature of medial nerve, which basically supplies few muscles: pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis. And in anterior interosseous, nerve supplies flexor digitorum, flexor pollicis longus, pronator quadratus. And as the nerve goes below, patient has essentially medial nerve is supplying abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and first and second lumbrical. Just a brief information about the muscle supply, and all of these things gives us some information about which muscle gets damaged, and then proceed in that direction and focus on that nerve as a cause of entrapment. Now we're going to specifically talk about medial nerve today. Now, there are 4 potential sites of compression for pronator syndrome. Pronator syndrome means when the medial nerve is compressed by pronator muscle or something close to the pronator muscle. Now, there are 4 segments of medial nerve, or 4 areas close to the elbow. The medial nerve gets compressed. Number 1 is the distal third of the humerus beneath the supracondylar process, and the ligament of Struthers, which compresses medial nerve. This is above the elbow. Lacertus fibrosus is at the level of the elbow, which is a fibrous structure, and that can compress medial nerve at the level of the elbow. And pronator muscle, which is actually below the elbow joint kind of stuff, which can also cause compression by aponeurotic fascia between the superficial and deep heads of the pronator teres muscle. And beneath the arch of the flexor digitorum superficialis also, the medial nerve can be compressed. The knowledge of this anatomy, as you're seeing here, tells you at what point which nerve is creating the compression, as well as this will give the information that if we know exactly which part of the medial nerve, whether it's above the elbow or below the elbow, compression by clinical finding, etc., then we can approach, or our surgical approach of releasing this will change according to the location of the nerve entrapment. It makes sense. And there are certain studies, we'll talk about it, or tests, we'll talk about it, which is going to tell you which part of the medial nerve is compressed, but which segment of the muscle, whether it's ligament of Struthers, or it's pronator, or it's a Lacertus fibrosus, or flexor digitorum superficialis muscle. Again, just to show what the pronator teres muscle is, and if you cut it, where the medial nerve is going through between the superficial and deep muscle belly of the pronator teres muscle. By the way, this looks simple. This ulnar artery, etc., is sitting very close to it. So during surgery, one has to be extremely careful. Another picture of the same anatomic structure in a kind of a diagrammatic way. Clinical findings of pronator syndrome would be pain in the proximal volar surface of the distal arm and forearm, which is aggravated by active muscle flexion. Numbness, paresthesia, or sensory symptoms in the radial 3.5 digits, namely in the medial nerve distribution. Phelan sign at the wrist is negative, and signs are not limited to the proximal forearm, especially loss of flexion of the DIP of the index and IP joint of the thumb, or benediction sign, is a sign of basically pronator syndrome, because the muscles of the flexor pollicis longus and flexor digitorum profundus muscle is not functioning. So when the patient wants to make a fist, index finger and thumb stay straight, giving the appearance of a benediction sign, period. Now, keep in mind, the numbness we see in the hand is pronator syndrome. You also see it in carpal tunnel syndrome, but you don't see numbness in anterior interosseous syndrome. So keep that information in mind. Now, the maneuvers which tells me exactly where, which part of the median nerve is compressed, whether it's above the elbow or below the elbow or at the elbow, depends on this few clinical tests, which is not done on a routine basis, but these are very helpful. Namely, when the Strather's ligament is the cause of compression, flexion of the elbow against resistance between 120, 135 degrees will cause the pain and symptoms. Active flexion of the elbow with the forearm in pronation, if that elicits pain and tingling numbness, this is from Lasarter's fibrosis, mid-elbow kind of stuff. Now, pronator muscle compression, resistance to pronation of the forearm with flexed wrist, that you have just made the pronator muscle tight, creating more compression. And the arch of superficial muscle compression is tested by resisted flexion of the superficial muscle of middle finger. So this limited test gives us some idea which part of the median nerve is compressed and what could be the cause of the median nerve, cause of this pronator syndrome, which is almost has 4 segments of compressive sites. As the median nerve goes distally, the median nerve can be compressed in the forearm area by, again, some compressive factors. This causes anterior interosseous syndrome. Basically, the median nerve can be compressed by the deep head of the pronator teres and the origin of flexor carpi radialis muscle. Now, remember one thing. This is just starting when the pronator syndrome has ended and the anterior interosseous syndrome has started. Again, accessory muscles, FDS and FDP compression is there. There's a muscle called Ganser's muscles, accessory head of the FPL muscle, that can also cause the problem of anterior interosseous syndrome. By the way, remember this name, Ganser's muscles, because it's always in the board exam, though hardly anybody has seen this muscle. There are vascular compromise is possible, thrombosis of the ulnar collateral vessels, trauma, supracondylar fracture of the humerus, mid-third fracture of the radius, penetrating wounds, and sometimes even Volkmann's contracture can cause the anterior interosseous syndrome. But Volkmann's contracture is clinically very identifiable. Iatrogenic injection, flexor pronator slide operation. This is an important factor to know. Flexor pronator and slide procedure can literally cause anterior interosseous syndrome because the muscle, etc., essentially causes scar in that area. In other words, you can also have enlarged bicipital bursa, tendinous origin of the palmaris profundus muscle, and flexor carpi radialis brevis muscle. This is where the anterior interosseous nerve going through, as you can see, the fibrous arch of the flexor ilium superficial muscle is going basically anterior interosseous branch of the median nerve. By the way, anterior interosseous branch of the median nerve does not have any sensory component. As a result, the anterior interosseous syndrome doesn't have any tingling numbness of the hand compared to pronator syndrome and carpal tunnel syndrome. The anatomy, the anterior interosseous nerve arises from the median nerve about 5 to 8 centimeter distal to the lateral epicondyle and innervates FPL, and FDS of the middle finger, pronator quadratus muscle also. It supplies the wrist joint. Just to throw in, Martin-Gruber anastomosis is a communication from the median to ulnar nerve, which occurs via anterior interosseous in 50% of the cases. The way I remember Martin-Gruber, which nerve to which nerve, is basically M stands for median nerve, so median nerve to ulnar nerve. So Martin starts with M, so keep that in mind if you have to answer some questions. Clinically, anterior interosseous syndrome, also vague pain in the proximal forearm, aggravated with activity, and inability to make O sign when asked, patient assumes an unusual posture of pinch. Weakness and paralysis of FDS of the index and FPL and pronator quadratus muscle. There's no sensory deficit. There are other diseases which may mimic anterior interosseous syndrome, Parsonage-Turner syndrome, which is basically an idiopathic brachial, lower unit of brachial plexus neuropathy, but it starts with an acute pain in the scapular area as well as weakness. Mannerfeld syndrome is another one where, for some reason, there's an attrition rupture of the FPL, as we see in the rheumatoid arthritis Kiene-Box disease, which essentially erodes the FPL tendon, resulting rupture of the FPL tendon, and patient cannot make or flex the thumb, suggesting that it's possibly anterior interosseous syndrome. Congenital absence of FPL, FDP will also give the similar kind of problem with the creation of sarcal sign. Partial lesion of the lateral cord or the medial root of the medial nerve can create, give this appearance of anterior interosseous syndrome. In irreparable nerve, by the way, FDS of the ring finger to the FDS of the index and FPL of the thumb, and ECRL to flexor digitorum profundus of the index and middle finger can be done, which gives functional recovery to at least the functionally patient do well. This is a classic area to some extent where you see anterior interosseous nerve pain, and compression of this area essentially can cause tingling numbness of the hand. This is a sarcal sign, basically patient with intact FPL tendon of the thumb, they can flex the thumb, IP joint, and FDS and FDS, FDP of the index finger, they can make a sarcal sign with an anterior interosseous nerve compression. The patient will end up making a sign almost like this. Now, medial nerve, we'll be talking about carpal tunnel. Remember one thing, the medial nerve at the level of the wrist, this is a kind of a, not a good picture to some extent, because medial nerve does not supply the thinner aspect of the thumb. It only supplies the fingers. The thinner aspect of the thumb is supplied by palmar cutaneous nerve or the medial nerve, which arises above the level of the transverse carpal ligament, as well as it goes superficial to the transverse carpal ligament. So carpal tunnel syndrome, patient essentially comes up with weakness, clumsiness of the hand, numbness, and hyper or paresthesia of the radial 3.5 digits. Aggravation of symptoms with work, especially with grasping, etc. Patient wakes up at night because of pain, burning, and numbness. And patient also has pain in the wrist level, which radiates to the elbow sometimes. It radiates to the shoulder, etc. Male to female is to be 2 to 1. Or male to female is 2 to 1, but it used to be just reverse. 50% of these patients are between 40 to 60 years of age. The other conditions which are associated with carpal tunnel could be rheumatoid arthritis, multiple myeloma, amyloidosis, local trauma to the wrist, hemophilia, pregnancy, median artery thrombosis. Local trauma to the wrist, essentially, if they have an irregular reconstruction of the wrist, either in the Colles fracture, which has healed in unsatisfactorily, or if it's been operated with a plate, etc., people have to look at the wrist to see whether that mechanical factor is causing the compression of the median nerve or not. Similarly, median artery thrombosis can cause acute carpal tunnel syndrome, which can be diagnosed to some extent by MRI. The patient usually comes up with acute pain. And these are the only patients in acute carpal tunnel which needs to be operated, I think. Distal radial fracture, as I just mentioned. There are aberrant muscles like anomalous lumbricals, flexor superficialis, etc., can create carpal tunnel syndrome. Release of the transverse carpal ligament essentially sorts this problem out. In addition, systemic causes like diabetes, hypothyroidism, alcoholism, local tumor, gout, menopause, vascular tumors, all can cause mechanical and systemic reasons for carpal tunnel syndrome. And for management, one has to know all these things because your decision whether to do surgery or medically manage it depends in having this kind of information handy. Anatomy, by the way, is transverse carpal ligament attaches to the scaphoid tubercle as well and trapezium on the radial side, and pisiform and hook of the hamate on the ulnar side. So sometimes the patient with the fractured hamate can present with the symptoms of carpal tunnel. X-ray, etc., usually clarifies that information. Transverse carpal ligament used to be called flexor retinaculum. We don't call it anymore. But remember, volar radiocarpal ligament is not flexor retinaculum. So transverse carpal ligament is the culprit, not the volar radiocarpal ligament. By the way, palmar cutaneous nerve arises, as I just talked a few minutes back, from the distal third of the median nerve and divides into median and lateral branches and responsible for sensation to the thinner eminence, proximal 2/5 of the palm or the radial side, usually unaffected by carpal tunnel syndrome. So remember one thing, in pronator syndrome, this nerve is trapped way far above, so the patient has diminished sensation across the board, namely palm, thinner eminence, as well as the digits. But in carpal tunnel, thinner part of the thumb is usually not numb. There are various anatomic variations of the median nerve. Knowledge of this, to have this information is important because the motor branch of the median nerve comes in various different format, and which people ought to know for a simple reason. When you do endoscopic surgery, these branches, which are coming from a different part of the transverse carpal ligament, whether it's extraligamentous or intraligamentous, can create problem, and there's a chance or possibility one can damage this nerve. Clinically, there's no way we can figure it out where exactly and how exactly this nerve is coming out from. And there are about 13, 14 variations, and you can see here that how many types of variations you have in the thinner branch of the median nerve. Again, how do you diagnose carpal tunnel syndrome? Symptoms, obviously, tingling, numbness, and the finding-wise, the patient usually gets decreased grip strength, decreased sensation in the median nerve distributed finger, which is radial 3.5 digits, diminished sweat pattern, thinner atrophy. Patient usually have positive tenile, patient at the level of the wrist, weak abductor pollicis brevis muscle. Then patient also gets Phelan's study, or Phelan's sign is usually positive. There's a sign which is described as a Darkham sign, which is basically compressing the median nerve at the level of the wrist and then elicit the Phelan sign. That is much more effective. And patient has normal FPL to the thumb and FDP to the index finger. That means patient can make a circle without any problem. Patient also has normal sensation to the proximal palm because it's supplied to the palmar cutaneous nerve. And patient's symptoms can be elicited if you put tourniquet up. Diagnostic studies, though it's not absolutely needed, X-ray of the wrist is indicated when patient has a history of old wrist injury, surgery in the wrist. One has to rule out that that's not the cause of the median nerve compression. MRI in select cases, especially recurrent disease, to rule out incomplete release of the carpal tunnel, as well as anomalous muscle, prior trauma, vascular malformation, or thrombosis as a cause of carpal tunnel syndrome. The most important study which we do is EMG and nerve conduction velocity studies. And lab studies has to be done to rule out systemic problems like rheumatoid arthritis, hypothyroidism, diabetes, etc. Treatment basically is patient education, ergonomics, namely how the patient puts the wrist up during work or using computer, etc. Splinting is beneficial, at least for a short period of time. Rest and exercise is important, both at some point. Steroid injections can be given to temporize the pain, and sometimes it does relieve the patient the symptom for a long period of time. High dose of vitamin B6 have been suggested, and most of the time, if the medical treatment or conservative treatment fails, patient is advised to get open carpal tunnel release or carpal tunnel release surgical. Now, surgical options can be classic open carpal tunnel release, which with a fairly large incision coming from above the wrist going all the way up to the palmar, up to the palm. It's not very many people does it anymore because smaller incisions are working out very well. Endoscopic carpal tunnel has been practiced for a long period of time. The positive part of endoscopic carpal tunnel syndrome is the incisions are small, patient's recovery is short. The negative part is this, again, the chances of incomplete release can be pretty significant from time to time. An old anecdotal study has been done long back, which suggested that there may be at least about 40% chances of incomplete release. Now, I'm sure that kind of slowly goes away once the learning curve gets better. But again, injury to the motor cutaneous branch of the thumb, ring finger, flexor tendon, etc., has been seen. And even in our practice, we have seen multiple incomplete release, motor branch of the median nerve damage, etc. Minimally invasive procedure, when you make a small incision in the palm, you can visualize both sides of the transverse carpal ligament, and you can release visually. There are people who have suggested laser surgery doesn't work. Tissue expansion can work for a very short time, but that's not a common procedure, and it's not recommended. Recurrence of carpal tunnel surgery can be because of few causes. Number one, incomplete division of the transverse carpal ligament, obviously. Postoperative scar formation, which can happen. Mostly the people who are not moving the hand after surgery, or people who are being splinted for a long period of time. Complete division without complete relief of the symptoms due to missed pathology, like tumors may be missed, aggressive tenosynovitis may be missed, or some kind of an abnormality there which we are not addressing, that can cause a continuation of symptoms despite of a complete division. And some patients, even with a good carpal tunnel release, has a persistent symptom. This is about 25% of the cases, though the symptoms are less, but it's not completely gone. By the way, the reoperative rates are only about 0.5%, which is helpful for that. This ends our discussion about the median nerve compression. And at another day, we'll discuss about ulnar nerve symptoms. Thank you.